So I hope you're enjoying your lunch. I'm Dr. De Jesus. I've seen you around. Okay. Today we're going to talk about coma and brain death. So every time a patient comes with any type of brain injury, we always think like a noxic brain injury, but also in the ICU, we are using more and more the term devastating brain injury or catastrophic brain injury, and that's when you have severe, moderate to severe traumatic brain injury or intracerebral hemorrhage or very big stroke in the pons area. Your patient can become comatose, and from there, you will have to do neurological exam to decide what is the real state, right? So not really coma, actually locked-in syndrome is an awake patient that has intact cognitive function most of the time. Sometimes they fluctuate because even when they sometimes wake up and can follow commands and kind of interact with their surroundings, and the reticular activated system sometimes is damaged in a way that they just fall asleep. They go into a brief comatose state and then they wake up. So not all of them are always 100% awake. So, but these patients, you have to have a high suspicion and always open the eyes of your patients, ask them to look to the right, to look to the left, to look up, and see if they follow any type of commands. That will be your locked in. So there is another phenomenon that is the chronic coma that is very rare. And it's basically this patient that is not awake, not aware, GCS of 3. Well, supposedly it's just GCS less than 8, but could be GCS of 3, 4, 5, like posturing. But this is very rare. Usually all the comatose patients and basically transition to either brain death or to vegetative states. And then the vegetative state, these patients have eyes opening, can be spontaneous, can lead to stimuli, and they have sleep-wake cycle. And that's basically how you describe vegetative state. From vegetative state, they can become permanent vegetative state. And so that's more than 3 months. It is not TBI. If it's a TBI, usually we wait up to 1 year to say that something is persistent and it's not going to change, especially if you have a very young patient. Or they can actually improve to minimally conscious state. This is the patient that may track around, that actually may try to make some sounds and scratch themselves, do purposeful movements, but it's minimum what they do with the interaction with their surroundings. But minimally conscious state, they can stay there, have some sort of spectrum up to evolving independence and a normal human being. So coma, it's when you don't have, you don't wake up and you're not aware of your surroundings. And usually the brain lesions are bilateral and involving the thalamus or the brainstem. And you also can have all these type of intoxications that also affect both hemispheres. And this can be medications, intoxications with opiates is usually the most common, and status epilepticus, or some sort of metabolic disorders, or meningoencephalitis. So when you talk about coma, GCS is less than 8, and usually the best that they do is they do eyes 2, verbal 2, motor 4. Can someone tell me what does that mean? What is eyes 2? Open spontaneous?
So just painful stimuli.
Oh, yeah, to painful. Eyes to pain.
Vocal is it's like grunting, it's like no incomprehensible sounds.
Incomprehensible.
And then 4, that is it's withdrawn.
Withdraw. And then what happened with the GCS is like really doesn't talk about anything. Doesn't talk about the pathophysiology, doesn't actually give you the chance to check if your patient is locked in or minimally conscious. You don't check the brainstem reflexes. So a GCS of 3 is a GCS of 3 for everyone, doesn't say much. And they give a lot of importance to the motor response, and that's kind of unfair if you have a spinal cord injury, like a quadriplegic. This patient can be awake and talking or maybe intubated because they're not protect the airway. And then you're saying that their GCS is 5, 6, and they are not comatose, they are awake, it's just they cannot move. And then you have the limitations if you have an intubated patient that your verbal response is always going to be 1. And so people notice that the GCS is not the best. It's mostly like a neurosurgical type of assessment, quick. You can definitely interrelate to the same patient to their GCS if they improve or decline, but you cannot compare among your patients. And someone developed this full outline of unresponsiveness scale or the 4 scale. And in this one, you have the opportunity to check for brainstem function, the respiratory pattern, recognize the locked-in states, and actually you can recognize early herniation signs. So this is a Glasgow Coma scale. So just for showing up, you have a 3. So GCS of 0 doesn't exist. That's usually a tricky question. And the maximum is 15. And motor response, if you don't do anything, is 1. If you expand or decerebrate, is 2. Plexus or the corticate is 3. Withdraw is 4. Localizing is 5. And following commands is the best, and 6. The best verbal response is nothing, is 1. 2 is this incomprehensible or moaning sounds. 3 is inappropriate words that don't even relate to whatever you're asking. And 4 is your patient is confused, but kind of relevant and appropriate to the question that you're asking. And 5 is oriented. And then eye opening is 1 not opening, 2 they open to pain, 3 they open because you told them or to verbal stimuli, and 4 they open spontaneously. So the 4 scale, it's a little bit more complicated, but more comprehensive. And it goes from 0 to 16. And usually your 0 is either brain death or in convulsive status epilepticus or subclinical status epilepticus. And your 16 is normal patient. You want to go through this? We can go through it. I just don't want to bother you, like bore you too much with that. But basically your eye response, it's similar, 0 to 4. Your motor response is also 0 to 4, it's not up to 6. And they call it the 4 scale just because 0 to 4. There's not more than 4 when you are normal. And brainstem reflexes, basically 4 is that you have your pupil and your corneals, and then depending on what you're not having, you're graded. And they include your respirations from your normal, not intubated, to your patient is breathing at the base rate or apneic. And this is interesting. I seen this in the neurology boards. So for you guys, for sure they will ask something like this. And they can give you the breathing pattern by the name or just by the graphic, and ask you the localization or what is important or what is the next step. And Chinese stokes, I think we all recognized pretty, it's pretty common. We see this in our patients. And basically it's shallow to deep respirations and then apnea. Basically we do, and then they stop. And can be mostly intoxication, but also people has been related this to diffuse brain injury. carbon monoxide, opiates, and intoxications. The biots respirations is always deep breathing and fast, and then apnea. So that's the difference. That the Chong Stokes, the deepness of the breaths are different. And this one, they relate to the medulla injury. And Kussmaul is you are always very deep and fast breaths. And this is the usual severe metabolic acidosis, like diabetic ketoacidosis, and you see your patient just with labor breath. And then the agnostic respirations, I've never seen it or recognized it, but they describe it as you have very deep inspirations, and the patient kind of stops, and they have deep expirations, and then apnea. And this is PONS, supposedly. And then the ataxic respiration is just very aberrant. The patient can be having seizures, or your patient is basically pending herniation. So what to do? The first thing you want to check is obviously ABC. Make sure your patient is breathing, is protecting their airway, doesn't need to be intubated, that is hemodynamically stable. And then you want to make sure there's nothing that you should be aware of sooner rather than later that you can reverse. So check your electrolytes, especially your sodium, right? Your potassium, your calcium, and glucose levels, hormone levels, TSH, T4, ammonia if your patient has a history of cirrhosis, and obviously toxicology. You can give Narcan, you can give for the Ativan. We rarely use it to prevent benzos.
Oh.
I can't believe I forgot. Narcan is for opiates and to reverse benzos. Flumazenil, thank you. Some patients that you give Ativan to give to the MRI and they become too sleepy, we can give them flumazenil. It's true, the patients can have seizures, but it's better that a little bit of a seizure than having to intubate and come with all the complications that can happen after intubation. And obviously, your patient has blown pupils, is localized, and you want to have your CAT scan, make sure there is not any structural lesions. Brain MRIs are more sensitive for ischemic stroke, especially in the posterior fossa. And EEGs for patients that may be having subclinical or non-convulsive status epilepticus, and then spinal taps, obviously, to rule out any infection, inflammatory disease. So basically, this is an easy chart. If your patient is conscious, this is not what we're talking about today, but basically it is yes. And if they are not really following commands and interactive as you expect, then you have to think about minimally conscious states, because they fluctuate and they may do a couple of things, but not all the things that you're asking for. And if they are interacting, but only with their eyes, then it's a locked-in syndrome. But if they're interacting and more interaction than you expect from locked-in, so they move around or they do more purposeful movements, you think also in minimal conscious states, or someone who is just disabled, but that may recover. Now, if your patient is not conscious, you need to check your brainstem reflexes. And if they do have brainstem reflexes, you have to see if your patients open sizes continuously or have sleep-wake cycles. And if the answer is yes, that's the vegetative state. If that's not the case, the patient is in coma. And if your patient doesn't have brainstem reflexes and then you check an amnia test, your patient is brain dead. Then we know from vegetative state, they can become minimally conscious state and maybe recover. So in 1981, and after Cushing doing all his experiments to notice that if you have increased intracranial pressure, you have the Cushing triad. And they started noticing that there were these severe coma patients that eventually developed respiratory failure that then led to cardiac arrest. And so they knew that there was this type of irreversible kind of brain death, but no one really described it completely and was not legal. Um, so they did the Uniform Determination of Death Act, and they say, yeah, if you have circulatory and respiratory function cessation or a cardiac arrest, you're dead, and we already know that. But also, if you have irreversible cessation of your entire brain functions, including your brainstem, then you're also dead. And that's the first time that we have a legal document saying that, and all the 50 states and are supposed to follow this determination.
But I don't think they all follow, right? I think New York and New Jersey still follow that for brain death. That's what I heard. I don't know for sure.
We all follow it. It's controversial. For example, in Nevada,
Mhm.
someone sued one of the hospitals because their brain death protocol had a deviation from the brain death protocol in other hospital, and they didn't believe that the patient was brain dead. And actually, they won the whole argument just because it's true. We don't have a real protocol that everybody does. So some hospitals do only one brain death exam followed by an apnea, and that's it. Some hospitals like us, we do a brain death exam, we do an apnea test, we wait a couple of hours unless we do a confirmatory test, and then we do a second confirmatory brain death exam. And we do it because our population is more difficult and because we know there's still a lot of education lacking in what brain death means. So to avoid that type of controversy, we do the two brain death exams. But legally, brain death exists. Brain death is death legally.
Yeah, right.
It's just these little details on every single state that you have to follow your state rule, and on top of your state rule is the uniform act. And yeah, what you mean is like they keep the brain death patients
No, I always heard that.
on ventilators.
Yeah, I mean, I don't know.
And they transfer to.
Yeah. So I think New York and New Jersey, for them, brain death is not legally death. But
So
it is in all the other states.
No, it is.
It is, okay.
It is. It's just they are right now the only two states that leave the patient connected to the ventilator until the cardiorespiratory death happens. Yeah. And it's just because of that, because we have seen people suing and they win these cases because we lack uniformity. So something that we're trying to do is all being in the same page and trying to do a kind of protocolized brain death examination so people really believe in what we're saying, right? And the American Academy of Neurology actually has been trying to do this for a very long time. This is from 1995, but sadly, the different hospitals kind of made their own approach and their own protocols. So you always have to make sure that you are familiar with the protocol and the hospital that you will be working for. And they basically say if you have a reason to be in coma, you already discarded like reversible causes of coma, like electrolyte disturbances or some sort of endocrine crisis, hypothermia, intoxications, or some sort of medications that you get to the patient. If you have a neuroimage that explains the coma, right, like diffuse anoxic brain injury or severe catastrophic intracerebral hemorrhage with herniation patterns, it's kind of easier and more visual. And if you can get an auxiliary test, it's even better. It kind of confirms absent cerebral blood flow. So if you have those with your neurological exam, no motor response, no brainstem function, then your apnea test goes above the baseline PaCO2 for at least 20 points or more than 60 millimeters of mercury, then your patient is brain dead. And then this is a whole new movement, or it's not that new because we've been doing it since the 80s, 90s. But now more and more people are accepting and understanding that if you're brain dead, maybe from this tragedy, you can bring something good, some hope to the family, that if they are potential donors, they can be organ donors. If not, usually we disconnect from the ventilator, and we try to do it within 24 hours of the confirmation of the brain death. And so this is a picture that Give of Life gave me for a talk that I did for them. And this is your normal MRI brain, right? All your soul size are preserved, gray, white matter differentiation. You can see all the cisterns open. You have a space around your brain structures. And then this is a brain death patient that herniated while he was having the scanner. And you don't see those soul size anymore, right? This is the cerebral edema. And I would say here, I don't see any gray white matter differentiation at all. Maybe some here, maybe. And then the patient has hydrocephalus, and most likely it's obstructive hydrocephalus because your cisterna magna, your foramen magnum is all crowded, and you have tonsillar herniation. You kind of also are having central herniation, and basically all these causes brain death. The medulla gets pushed in, and our respiratory and cardiovascular centers stop working. And then you can have cardiorespiratory arrest after that. So determination of brain death. And the first thing that you do is you stimulate your patient. You can start with verbal and then loud noise, and then you do your painful stimuli. I always go for the trapezius because it's very painful and uncomfortable. And if your family members are around, I suggest to not go for nipple squeeze. And I admit that I do it when I am not sure and I want to make sure that my patient is not doing anything. But if my family is around, I don't do it. Kind of not kind. And so you're not supposed to have any response unless it's a spinal reflex, and we will talk about a couple of them. The most common is the triple flexion. And so that's your DCS of 3 intubated. And then you check your pupils with your bright light. Basically, an afferent is 2, efferent is 3. And corneal reflexes, you can use a cotton swab, or some people uses the eye drops or flushes, a little bit of flushes into the eye. And I like to do it in the limbus, basically in the area after the iris, really touch into the iris. And basically, if your patient blinks, is present. If your patient doesn't blink, is not present. And this is afferent 5, efferent 7. And then you do your oculocephalic. Basically, you have to hold your patient's ET tube and do like really brisk movement side to side. And this is your normal reaction, right? If your eyes are going to look away from the side that you're turning the head. And this is an afferent 8, efferent 3 and 6. And if it's not present, that means that your patient is awake. If in an awake patient, it will look wherever you move the head, or in your patient with absent instant reflexes. We will do the same. And then you do cold calorics. There is afferent 8 and also efferent 3 and 6. Basically, you infuse water, 50 to 60 ml, cold water, into the eye, into both ears. And the normal response, as you can see here, is that your eyes looks towards the stimuli, and then the pars nystagmus is away from the stimuli. That's the cause. Actually talks about the nystagmus. And and if your patient doesn't have any eye movements, then you have absent caloric reflexes. You always should wait at least 30 seconds to 1 minute between the checking ear, each ear. And then gag reflex, you can either push your ET tube in or use the suction. Directly try to stimulate. That's your afferent 9 or afferent 10. And your cough reflex, you literally have to suction the patient all the way down. And that's tense on both sides. And then if you don't have any of these reflexes, you can tell that at least your first brain death exam is consistent with brain death. So our brain death policy, I don't want to be jumping around, but I want,
No, it's okay. Just don't close it.
But I wanted to show you something. This was just revised, and for this January, hopefully we will have a new brain death policy. Can I make this bigger?
Yeah. Maybe page width. Down the right.
Oh, perfect. Okay. So hopefully, oh no, we will have this figured out and approved by January 2019. And our brain death policy, as I explained, we need 2 brain death exams, and we don't specify that has to be a neuroscience physician. Can be one of the examinations can be either a neuroscience physician or a board certified intensivist, and the other examination can be PGY2 or above that has experience on brain death. Yeah, that's the tricky part. Actually, we are working on putting together a workshop with our SIMS lab. So everybody gets this training, and then we can tell people, yeah, his experience, he has these many hours in the SIMS lab, and he knows how to do a brain death exam. And then if you're not getting any ancillary tests, you have to wait 6 hours in between the 2 exams. Unless it's anoxic ischemic brain injury, then you have to wait 24 hours. And then this is the major change in the brain death policy. Right now, we do the 2 exams and then an apnea test. Right now, we changed the apnea test to be done after the first brain death exam, and that is consistent with brain death. And again, if your PaCO2 increases by a minimum of 20 points from the baseline before the apnea test was started, or it's more than 60, confirms your brain death. Or if you have a COPD patient, that sometimes they live in higher CO2 levels, and you need acidosis or hypoxia to say that your patient and apnea test is consistent with brain death. This is the form that we right now fill, and it's in the paper chart, but eventually this is going to be part of the EMR, and we still don't know if it's going to be 2 different forms or if it's going to be one form to be filled, and with the first exam by the first physician, and then the second exam by the second physician. Then you have all your brain death determination in the same type of document. And obviously you need your date, your time, and we always want you to notify Gift of Life. The sooner you identify a patient that is having a catastrophic brain injury that most likely is going to progress to brain death, the better. Sometimes if the patients improve because you did a great job, they just step out and no one even noticed that you called them. But it's better to call them earlier rather than later. And we never talk about organ donation. Actually, we let that to them. They are trained specifically for that, and so we can introduce them like this person can talk to you about other options or what to do in cases like your family member, but we try not to get in there because then families think that we really don't want to take care of the patient because we want the organs to be donated. It's better to stay away from that. And then we want to make sure we rule out all the reversible causes of coma or brain death-like states. And so our temperature, we're gonna make it greater than 35. We will make sure that drug intoxication or sedation is ruled out. Your systolic blood pressure is greater than 90. And no, obviously no neuromuscular paralyzing drugs. And this is just to establish that the patient has an exam consistent with brain death or the brainstem reflexes. And then for the amnia test, you will have the pre-PaCO2 and then the final PaCO2, including for those with COPD. And then confirmatory or ancillary tests that has been used, the results and the time that they were done.
So you never do a brain death test if the patient is over breathing the vent, right? Because it's
No, no. No, you can, what I do in those cases is I document the patient has an exam consistent with brain death, absent brainstem reflexes, but still over breathing the vent. So we know it's not brain death. So let's talk a little bit about the apnea test. And please, if you have questions, stop me. So first of all, you need your clinical exam consistent with brain death, and we already talked, like, at least in our policy, and again, I'm going to specify this because other you're going to notice what is the policy in Jefferson, but you're going to notice is that usually some people are more conservative and they do a temperature greater than 36 with a systolic greater than 100. Like I train in Jackson Memorial Hospital, and that's what we did all the time. And so it's important that you review your policy as soon as you know that you're going to be declaring people around brain death. And so we already went through this. And then how do you do an apnea test? So you want to pre-oxygenate your patient with 100% FiO2 for at least 10 minutes. Some people say 30 minutes. 10 minutes is fine. And draw a baseline ABG if you didn't have a morning ABG that has your PaCO2 35 to 40. Your morning ABG is fine. It doesn't have to be exactly pre-apnea test. And then you don't extubate your patient, just disconnect the ventilator from the ET tube, and you put this nasal cannula or some sort of tube that they prepare to put down the ET tube to the level of the carina with 100% oxygen. And you basically, I always uncover the chest of my patient, and you as a physician there next to the patient, your main job is make sure that that patient is not having respirations, that the chest is not moving, that they are breathing. And sometimes they hiccup, sometimes they're hard, they're hyperdynamic if they are on vasopressors. So you have to be careful to not overcall your breathing, but also you don't want to do an apnea test in someone who's breathing. That can happen. And so usually you wait 8 to 10 minutes. And after that, you draw your ABG, and then you reconnect to the previous mechanical ventilator settings. When you have to terminate your apnea test, no matter what, is if you see your patient breathing, if your patient became hypotensive and unresponsive to your pressors, because usually I like to have my levofed bedside, even if the patient is stable, because with the PaCO2, you cause vasodilation, and most of your patients are gonna become hypotensive. And if the patient develop any dysrhythmias, or if they desaturate, and usually I use SO2 less than 88%. So if that happens, you always want to draw an ABG because maybe the PaCO2 raised enough so you can confirm your brain death, and you can use that apnea test. And then you reconnect to your ventilator, and then you terminate the apnea test, Now, if your PaCO2 didn't raise the value that needed to raise, or your pH for the COPD patients, then that amnia test was not consistent with brain death, and you're gonna use your ancillary test. On the other hand, I think this is pretty clear, right? So what are the ancillary tests that usually you can perform? The gold standard and the diagnostic, but I haven't seen that is the most commonly used though, is the 4-vessel angiogram. And basically, if by the level of C1, there is no blood flow coming into the brain, that's pretty obvious that your patient is not having perfusion. And the most commonly used in most of the institutions and is the cerebral blood flow study. That is basically a nuclear medicine study. And the same, we are going to see a picture. You see the red nose sign, and is that there is no, the intake is mostly on the nose, and because there's nothing going into actually the brain per se, or the empty bulb sign. And then EEGs, usually we don't use a confirmatory. They are helpful and can be an ancillary test to say, oh yeah, so this patient is electrocerebral silence. But there is so much noise in the ICU and so much artifact that most of your epileptologists don't feel like confirming brain death by EEG. And transcranial Dopplers, again, it's operator dependent, so it's not used for confirmatory tests, but obviously, if you have a good technician and it's telling you, I don't see flow, it's a high suspicion, and you can actually talk to the family about it. And so when you use your ancillary test, no matter what, well, if you have severe facial trauma, you cannot check your brainstem reflexes, either the pupillary or your oculocephalics or your cochlearyx, and or your apnea test cannot be done. Your patient became very high, like dynamically unstable, or the patient is on ECMO. And if your family says, "Hey, I want to get over this," like I've had this poor guy, I will never forget. He wasn't mated for cellulitis because he was an IBDA, and some friend apparently brought him something.
Oh, yeah, I had him.
And what's the cousin?
He was 20 years old, right?
20 something, yeah, 2021. And so he injected what we think is heroin, and he was found down because he's just getting antibiotics for cellulitis. He's not monitored, he's in a regular room. He was found down, hypoxic. He was not on cardiac arrest, hypoxic. When we cooled them and everything, because he already had a noxic brain injury in his chest. He was brain dead. Yeah, he was brain dead when we saw him. So just because he was so young, we tried to do everything.
And the family didn't understand anything.
But yeah, so thank God I was not there when everything happened, and the dad was very upset.
They didn't want me to.
But in the morning, he was already coming around and wrapping around his mind, and his family told me, I don't want to wait 24 hours, and that's like a thing that, can we get over this? I just want this to be over. And so that's another reason. You do that, and then after your ancillary test, right after that, you can do your second brain death exam, confirm, and declare. And also, these patients that develop severe end-stage renal disease, and we are not going to dialyze them because they have poor prognosis for meaningful recovery, and that UN of 100 something. And you're not clear, it was more than 24 hours the last time your patient had fentanyl, then you can also use your ancillary tests. So this is, I think, pretty obvious, right? This is the internal cerebral artery, internal carotid artery, and the anterior circulation. And this is your internal carotid artery, level of C1, and there is no blood flow. And then this is the empty bulb sign, or the red nose sign. Basically, all your agent uptake is up to the nose because we have a lot of capillary there, but nothing is coming into your brain. And then this is a normal EEG, and this is your electrocerebral silence, and you can only see the EKG artifact. So you see, it's hard for an epileptologist to say, I'm sure that's not the brain. They're sure, but you have to be careful. So what are the spinal and reflexes that we are going to be okay with the brain that patients have in our, maybe not okay, because some of them are very scary, but are not coming from the brain. So they can have tonic flexions, they can have head turnings and finger jerks. They have an flexion elevation of the arms and opistotonic posturings. They can sit up. They can have abdominal reflexes, plantar flexion, and then the most common one is the triple flexion. And what you want to see that these are a stereotype, repetitive movements, that they don't change, that they don't seem to have any purpose. And that's what can make you be clear that this is a spinal reflex and not actually a movement that your patient is not brain deaf. And please don't forget about your family members. We are very concerned. We are trying to make sure that we are resuscitating and optimizing our patient and doing all these things and calling the gift of life. But sometimes the family are just there, not understanding what is happening. So remember about talking to them and be clear. Use the language that they understand. Don't be ambiguous. And I always start if I think the patients are going to die or are dead already, I always start with, this doesn't look good. I think this is going to go well. Try to support, but at the same time, explain to them what is happening. And the nurses are very good understanding what the family needs, especially the ICU nurses. And sometimes a glass of water, a hug, and chaplain, social worker. Some of them have questions about who's going to take care of the financial aspect of my father or mother. Like, so social workers can help with that. And I tell them, okay, so you need to do this, do that, And then again, to be clear, we are going to start the brain death protocol, and that means that we think that your family member is brain dead, and this consists of these tests of the primitive reflexes, and if those reflexes are not there, then we are going to check if they can breathe by themselves, and depending on that, we will let you know, and give small information at a time. You won't have to do a lot of repetition. And so from the moment that you know that your patient is going into the brain death route and it's declared, then it's not saving the patient's life, it's kind of optimizing an organ function in case that your patient is a potential donor. So this is just, we are finishing time. And so medical and legal death can be cardiorespiratory arrest or brain death. A patient who is brain deaf is dead. The time of death is when you sign that second neurological exam consistent with brain death, or if you did the 2 brain death exams and then an ancillary test. The time where the ancillary test was read by the neurologist, by the neuroradiologist, is the time of death. And you can tell the family that time of death is this. But they can kind of, that's a more concrete way of seeing the brain death. And there is a lot of confusion. As you say, there are some states that they don't even disconnect the patients from the ventilator, even when they have been declared death, or patients that have been transferred from here to there, been there. So try to be like clear about what you say. If your patients tell you, like I had a family member and was like, well, I read all these things of family members that they wake up from brain death and blah, blah, blah. I always say, I don't know that specific case. And maybe that person was not brain dead. Maybe that person was comatose and they were confused. I don't know that case. I can tell you that your family member is this and that and the other thing. And then I always find this funny because this is a Puerto Rican troublemaker, and he was a very famous boxer. And so he was getting in trouble and he was shot in the head and he was declared brain dead Thursday and clinging to life. So even the media, he's declared brain dead, but clinging to life. Like, that doesn't even make sense in the same sentence, So be aware. There is a lot of confusion still. And that's it.
So,
Questions?
is that when you think when people do say like stories of family members waking up and stuff like that, assume was wrong? In those cases, like they were comatose instead of brain dead, or like do you have?
Or they were under sedation. Some patients are under sedation, they look brain dead or paralyzed. You examine a paralyzed patient,
Yeah.
they don't have brain because they don't have anything. So could be that, could be coma, could be vegetative state, could be hypothermia. It's hard. So I always say that I don't know that case. I was not there, but I can tell you how we do things here. Here we check this, that, check the other thing, or would you like us to do a confirmatory test? Would you like to see if there is no brain flow? And so there's nothing there. So yeah, it's very abstract, I think. Right? Brain death is not something that is straightforward. We are still struggling how to do the best protocol for the population that you serve and how to transmit that message in a clear way.
Yeah, it's really important, especially with family, because they don't really understand the difference between brain death and coma and vegetative state. They use it interchangeably, and they think they think patient who's brain dead, like they can still come back. They think it's just a coma. They think it's just like sedated or sleep. And it's really clear to like convey that message that brain death is very different from coma. Like, there is no coming back from brain death. So a lot of times, just family has trouble understanding that as well. Like really.
Well, I remember recently we had a very tough case in the CT surgery service. And the PA told the family, he's brain dead, and we are making sure that he's comfortable and not having pain. And I look at him, I'm like, I am going to stop you there because I don't want you to be confused. Because, this is a family that has no idea. They're super stressed out. You're telling them to disconnect the patient because he's dead, but at the same time, he's comfortable and not having pain. I'm like, when you're dead, you don't feel pain anymore. Like, you're dead. Your brain doesn't even understand. Your brain is not there. For you to have pain, you have to process all the inputs from your extremities and everything into your brain to understand what is pain, to feel it, right? So that's why it's everything you say has to be so. I speak very slow when I talk to them, just making sure I am saying the correct words. Because one mistake, and they are like, you said this. So, but brain death is dead. Brain death is dead. Okay. No problem.
Thank you.
Thank you. Do you want to save this somewhere?
The PowerPoint? I guess you could put it on the Neuro drive, share drive.
Do you want to?
Yeah, sure.
I don't know.
Oh, here. Just this, right? The document.
Coma and brain death. The
Oh,
one
okay.
behind that, yeah.